Hello everyone. Welcome to Green Nursing.
We will discuss about ECG. This is by far the most important topic for all the medicals. Sometimes you get confused after seeing the ECG. For example like this, and you think, is this normal? Should I call the cardiologist? So in today's video, I'll try to make ECG very simple in only 10 steps. And in the end, you'll be able to diagnose majority of algorithms on your own. So let's start. ECG or electrocardiogram. It is the graphical representation of electrical activity going on in the heart. Now how to read an ECG in just 10 steps. Before that, we need to check the calibration or speed of the machine, which is normally set at 25 millimeters per second. In most of the books on ECG,
first step is to calculate rate. You should know whether the rhythm is regular or not. I'll tell you the reason why when I'll discuss about the rate. So we will discuss the ECG interpretation in this manner. Rhythm rate axis, P wave PR interval, Q wave QRS complex, QT interval, ST segment and T wave. Now step 1 is rhythm. To check the rhythm, we check the RR interval. As in this ECG, RR interval are equal, and there is P wave before. Every QR is complex, so this is a normal sinus rhythm. In this second ECG, as you can see, the RR interval is not equal at any time, and there is no identifiable P wave. The rhythm is irregularly irregular, which occurs most commonly in atrial fibrillation. Now look at. This is easy. Normal regular rate with regular drop beat. So rhythm is regularly irregular, which is seen most commonly in second-degree heart block type 2. Step 2 it is to calculate heart rate from an ECG. If the rhythm is regular in ECG, heart rate is calculated by 300 divided by large boxes between other intervals. And this is a ECG graph paper. If the speed or calibration of ECG machine is 25 meters per second, then one small square corresponds to 2.0 per second, and one big square 2.2 second. So large 5 large squares is equal to 1 second. Now in this normal sinus rhythm ECG, there are 4 large boxes between RR interval. So the rate will be 300 divided by 4. That comes out to be 75 beats per minute. But if the rhythm is irregular, on ECG as an atrial fibrillation, rate is calculated by a number of R waves in 6 seconds, multiplied by 10 so as to get rate per minute. So in this ECG strip there are 9 R waves or 9 Kerr's complexes. So the rate comes out to be 90 beats per minute. So 300 divided by RR interval formula is valid only if the rhythm is regular. That is why we should first see the rhythm, and then should calculate the rate accordingly. Now step 3 is to calculate the axis. First of all, normal cardiac axis is from -32 plus 110 degree. And to know about the axis, we first need to know about the 12 lead XD. There are 3 bipolar leads which are lead 1, lead 2 and lead 3. And 3 unipolar leads which are augmented voltage lead, that is AVIA, AVIL and AVIV. And there are 6 chest leads which are from V1 to V6. Now to calculate the axis, most commonly we use perpendicular leads, that is lead 1 and AVIA. In this ECG, net Kerr's complex in lead 1 and in AV are positive. So if we plot these positive deflection on this diagram, we will get a vector in the normal cardiac axis range. So this is a normal axis ECG. And if net Kerr's is positive in lead 1 and negative in AV, the net vector will be in left axis deviation range. Lead 2 will also be negative in left axis deviation. And if net Kerr's is negative in lead 1 and positive in a VF, the net vector will be in right axis deviation range. Now look at this ECG. Net QRS in lead 1 is positive, and net QRS is negative in AVN. So this ECG showing left axis deviation or LED. And you can remember this by mnemonic left leaves, where net deflection in lead 1 and a VF are in opposite direction, or as if they are leaving, whereas in this ECG, Net QRS is negative in lead 1 and positive in a VF. So this is a right axis deviation, and you can remember this by a mnemonic right returns. Step 4 is PVE. So first of all, see whether PVE is present or not. If present, see the morphology. For PVE morphology, we'll look at lead 2 and V1. Height of normal P wave is less than 2.5 millimeters in limb leads and less than 1.5 millimeter in precordial leads, and the width should be less than 0.12 seconds. In this ECG, as you can see in lead 1, P wave are tall and peak. These are callers, people nail, which is seen in right atrial enlargement. And if P waves are bifid or have a notch in between, it is called as P mitrelle. Remember M shape for mitrelle, which is seen in left atrial enlargement. Step 5 is PR interval. It is from the start of P wave to the start of Q wave. That is why some call it as PQ interval. Normally it is 0.12, 2.2 seconds. That is 3 to 5 small squares. And it is prolonged in a V blocks, reducing WPW syndrome, in which there is an accessory pathway, which conducts impulses faster than the normal, producing shorter PR interval. And PR interval is depressed in pericarditis straight cases. Step 6, it is Q wave. It is called pathological if more than 2 small squares deep,
and usually indicate current or past MI.
as you can see, deep Q waves in inferior leads to 3 and avia. So this is ECG of old inferior vol MI. Step 7 is QRS complex. Normally it is 0.08 to 0.12 seconds. That is 2 to 3 small squares. It is widened in ventricular arrhythmias, which can be ventricular ectopic, or ventricular tachycardia or ventricular civilization, or any pathology below. Bundle of his. QRS is also widened in bundle branch blocks. In RBV there is M pattern in V1 and W pattern in V6. You can remember it with a mnemonic marrow, where double R is for RB and M in V1. W in V6 similarly. You can remember ECG of LBB by a mnemonic William, where W pattern in V1 and M pattern in V6 is present. Step it is QT interval. It is from the start of Q wave to the end of T wave. As a rule of thumb, normal QT is less than half the preceding error interval. And abnormally long QT is associated with increased risk of ventricular arrhythmias, especially TOS-RD pointers. Step 9 is ST segment. It is the flat isoelectric section of ECG between the end of S wave, that is the J point, and beginning of T wave. As in this ECG you can see ST elevation, which could be commonly due to
Acute myocardial infection or pericarditis.
If ST elevation is present in V1, V2, then it is septal vol MI. If in V3 and V4, then interior vol MI. If present in lead 1 plus a VL and V5 and V6, then lateral vol MI. And if present in 2, 3 and a VF, then it suggests infibrable MI. ST segment depression is seen in NSD-MI, myocardial ischemia, posterior MI, and many other causes. Coming on to last step, that is T wave. It is upright in all leads except a VR and V1. Tall, narrow, symmetrically peaked. T waves are commonly seen in hyperkalemia. Broad asymmetric, peaked or hyperacute T waves. They are seen in early stages of MI or ST elevation. MI inverted T waves are seen in myocardial ischemia or infarction, or can be in ventricular hypertrophy. Now let's discuss about how the ECG looks like in hypertrophy. In left ventricular hypertrophy, at deep street S wave in V1 or V more than 35 millimeters, then LVH is present. Whereas in right ventricular hypertrophy, there will be right excess deviation. RBS ratio, more than 1 in V1 and less than 1 or equal to 1. and V5 revolutions V6, and also our wave in V1 is more than 7 millimeters. This is the simplest criteria to detect RVH. So this is all about ECG. Always think of these 10 steps in this manner, and you will be able to detect majority of arrhythmias very easily, guys. If you like the content and information of this video, do like, share, and subscribe our channel Green Nursing. And also feel free to comment about the video. Thanks for watching this video.